Keep it on this. Bye.
Hi everyone, welcome. Good afternoon everyone, welcome to Unacademy, where you can crack all NEET PG exams with us with our top educators, quality content for great learning experience. So guys, let's crack NEET PG together. A little about me, I've done my MBBS from Father Muller Medical College, Mangalore, my Anesthesia from Father Muller College, Mangalore. So I've done my MBBS from Father Muller Medical College, Mangalore, and my MD in Anesthesia from Father Muller Medical College, Mangalore. I have 2 publications and 1 paper presentation in the field of anesthesia, and I've been working and teaching in Bangalore for the past 2.5 years. Today's topic, what we just did, it was fluid and electrolyte imbalances. We'll be completing the topic now. A little about Unacademy till then. It's one of India's largest online learning platform where you can get plus subscription and access to unlimited live and recorded courses, all from India's best educators. So what will you get out of Unacademy? Basically, we have our daily life classes. So we have classes where on a regular basis, so when you go to a coaching institute, there's a lot of, you have to get up, get ready. You waste time, energy. Once you reach there, again, you have to the whole thing about getting a good place. These are such big classes, and there are so many people, and the educator, it's very difficult for the educator to see that everyone, everyone's doubts are cleared, and also on the whole it becomes difficult even for the educator, for you all. But here you can chat with your educator, engage in discussions, clear your doubts and answer polls, and all this is while the class is going on. Then these are structured courses, so all our courses are in line with your exam syllabus, so they have all been prepared so that you will best be prepared for your exam, and whatever is required from NEET, based on that these courses are all prepared and by the various educators. Then of course we conduct live tests and quizzes, so we have regular tests and quizzes which will help you all to evaluate your performance on a regular basis. So after we complete a couple of topics, we conduct a quiz and all, uh, which will help you all complete your quizzes and tests. Then of course we have unlimited access to all our live and so there is unlimited access to all our live and recorded courses, and you can watch from the comfort of any of your device. So wherever you are sitting, whatever you all are doing, wherever you all are traveling, or whatever you all are doing, etc., from the comfort of your device, um, you all can watch. You all can basically watch. You know, your watch the class. Now these are some of our top educators. So these are some of our top educators: Dr. Nikita Nanwani, Dr. Preeti Sharma, Dr. Divish Mishra, uh, Dr. Mohammad Azam. So these are all our various educators on this platform. And Dr. Nikita Nanwani is also a NEET PG mentor. She's a NEET PG mentor for radiology as well as mnemonics and concept focusing, encompassing all subjects. Then we have So these are the various courses offered. So as you can see, there are a number of subjects on your screen. You'll have to cover all these subjects. I know it's not easy. It is very difficult in covering all these subjects and see. It is not. I agree. It is not at all easy to cover all these subjects and see to everything. And of course, there are certain subjects like your anesthesia, radiology, psychiatry, dermatology. So these subjects you all didn't really have to go into detail. But here for NEET PG, you need to know some details about these subjects. Otherwise, it will be very difficult. Very difficult from the point of view is that these are subjects where you need to you have to know something. You cannot give answer. You cannot expect to know the answer without going through these subjects. These are such subjects. These subjects are vast. But like how in your MBBS you all didn't have to go into very much detail into these subjects, so something similar here too. You all don't have to go into that much depth into these subjects, but you'll need to know some. It is still not that superficial enough for you all to just say that okay, I did it during MBBS, so it was okay, I can answer based on that. But no, you all have to go into slight amount of detail into these subjects, and these subjects have 11 marks each allotted to them. Very easy to score 11 marks. It's not difficult to get these marks, whereas with your physiology, anatomy, medicine and all, they have 44 marks each. They can ask you anything from anywhere. These are vast courses, so obviously they can ask you anything from anywhere. You all have spent a year after all studying about it, so it goes with that. These are some of the ongoing courses on our platform. Course on neurophysiology, GI surgery, cardiovascular thoracic surgery, respiratory system pathology, capsule on larynx. Now coming to the subscription part of it, as you can see, there are 5 types of subscriptions on the screen. Those of you who are giving NEET PG this year, this should suffice. For the rest of you, I would highly recommend the 12 and 4-month subscription. So these subscriptions are economical from the point of view that these are one-time subscriptions. After 6 months, you will have to subscribe again if you want to access the live and recorded courses. So you will have to access them again. Till then, whereas with this you have the buffer time, so I would advise. Plus this is something that you all are taking up for a lifetime, right? You all will be taking this up for a lifetime, so you all need to know that what you all will be doing for your lifetime, you all are going to enjoy. Then only there is fun in it, right? So to know that, then only you all, I mean, you all will get your satisfaction. So for that, that is why I highly recommend that. So these 12 and 24 months actually gives you time, to think about it and understand how, which subject you want, which you don't want. It was very helpful for me. So if you use my code at the bottom of the screen, SASHA, you can avail a 10% discount. Nobody is going to ask you how long you took to hear and all, so it's perfectly fine to drop. In our profession, nobody is bothered. At the end of the day, it is all about practice. Use my code SASHA to avail your 10% discount. Discount is applicable on all the types of subscription. So hurry guys. And again here for the 24 months subscription, use my code SASHA to avail your 10% discount. We will move on with the class. I will come to revision of the class later if time permits, because I want to stress on the class as such. This was just the initial part of introduction that we dealt with in the previous class, and now we will be dealing with hyponatremia. Sorry, some things have jumped in the slide. So now overall, a decrease in sodium in the extracellular fluid is known as hyponatremia. The 2 types of hyponatremia are seen: depletional and dilutional hyponatremia. So basically, there are hyponatremia, again like hyponatremia. So hyponatremia Assess extracellular fluid volume, low, normal or high. If it is low, to urine sodium. If it is normal, urine osmolality. And if it is high, again urine sodium, right? So if the urine sodium is more than 20 milliequivalents or less than 20 milliequivalents, this is more than 100, less than 100, more than 20, less than 20. So less than 20, cause is diarrhea, can be attributed to diarrhea. This is due to diuresis. High sodium osmolality is SIADH, syndrome of inappropriate excretion of antidiuretic hormone. This can be because of psychogenic polydipsia, drinking excess of water, and when the extracellular fluid is high urine sodium, renal failure, and this is heart failure or cirrhosis. When I'm teaching, you all can glance at this, will give you all an idea. So there are actually 3 types. So like depletional, dilutional. So there is hypovolemic, so hypotonic hyponatremia represents as an increase in free water relative to sodium. So hypovolemic hyponatremia is characterized by fluid loss combined with volume replacement using a fluid that is hypotonic to the lost fluid. So diuresis is replaced by drinking tap water. So a fluid loss is replaced by using fluid that is hypotonic to the lost fluid. So what is hypotonic to the lost fluid? The result is net loss of sodium relative to free water, which decreases both the extracellular volume and the extracellular sodium concentration, right? So renal sodium losses generally seen with diuretic overuse, adrenal insufficiency and cerebral wasting syndrome, whereas extra renal sodium losses can occur with diarrhea and persistent vomiting. So this is extra renal losses, that is when the urine sodium is less than 20 milliequivalents, that is extra renal loss due to diarrhea, whereas renal losses of sodium are due to diuretic overuse, adrenal insufficiency and cerebral salt wasting syndrome. So depletional hyponatremia, this is the sodium loss like diuretics, vomiting, chronic diarrhea, decreased aldosterone, decreased sodium intake, right? Then you have your isovolemic hyponatremia. So that was your hypovolemic. This comes under your hypovolemic hyponatremia. Then you have your isovolemic. So your isovolemic hyponatremia. The major disorder to consider are release of ADH and acute. So basically this inappropriate release of ADH, syndrome of inappropriate SIADH, not SAIDH, syndrome of inappropriate excretion of antidiuretic hormone, that and psychogenic polydipsia. So in this There is a small gain in free water, but not enough to be clinically detected. Acute water intoxication like psychogenic polydipsia, the urine sodium and urine osmolality the urine osmolality helps assess between these two. In SIADH, there will be more than 100 milliequivalents loss in of urine osmolality, and here it will be less than 100 milliequivalents. Your lastly is your uh, hypervolemic hyponatremia. So your hypovolemic hyponatremia uh, is basically loss of excess of sodium and water, with the water gain exceeding the sodium gain. So there is gain. There is basically in hypovolemic there is loss of water and sodium. In hypovolemic there is gain of both water and sodium, such that the water is more than the sodium, right? So it is basically a dilutional. So depletion is loss of sodium, dilution is because of the excess of water, it gets diluted. So this is seen with the renal failure, heart failure. In such cases, these are the common cause. So in renal failure, uh, the the clinical picture. So renal failure, more than 20 milliequivalents of sodium in the urine is indicated in renal failure, less than 20 milliequivalents in heart failure and cirrhosis. Okay. So dilutional hyponatremia, renal dysfunction with an increased intake of hypotonic fluids, excessive sweating, increased thirst, intake of excessive amount of water. Syndrome of inappropriate SIADH comes under your isovolemic, because here in isovolemic there will be no the extracellular fluid volume. Extracellular volume is normal. There is no depletion in the extracellular volume. Whereas with your okay, and impaired renal excretion of water, hyperglycemia attracts water. Clinical manifestations. So clinically, neurological symptoms. So the most feared complication of hyponatremia is life-threatening metabolic encephalopathy. This is the most feared complication of hyponatremia, right? It is often associated with cerebral edema, increased intracranial pressures, and seizures. So this can present with seizures. Seizures, raised ICP, cerebral edema. That is why for hypernatremia, we don't want to be decreasing the sodium value more than 0.5 milliequivalents per hour, right? So, uh, cerebral edema will be seen, increase intracranial pressures, and it can be accompanied by respiratory distress. So, correction of hyponatremia can also be associated with encephalopathy, that is characterized by demyelinating lesions, pituitary damage, oculomotor nerve palsy. So, if during hyponatremia, if the hyponatremia is corrected too quickly, it can result in demyelinating disorder known as central pontine myelinosis. Okay, it is irreversible, fatal, and contains and is very damaging. So, rapid correction of hyponatremia results in Okay, the other symptoms include cramps, weakness, fatigue, gastrointestinal symptoms like nausea, vomiting, abdominal cramps, diarrhea uh, can be seen. So the treatment strategy basically is, so the treatment is, so if the rate of rise in plasma sodium should not exceed 0.5 milliequivalent per hour, and the final plasma sodium concentration, so like I said, rate of rise of sodium should not, this is very important, exceed more than 0.5 milliequivalent per liter per hour, equivalent per liter per hour, and final plasma sodium should not exceed more than 130 milliequivalent per liter, right? So the treatment with a low extracellular volume, that is your diarrhea and diuresis and all that. Hypotonic saline, 3% NaCl can be infused in symptomatic patients, and isotonic saline. So this is only if symptoms are present, and isotonic saline in asymptomatic patients with the normal ECV. Furosemide diuresis with infusion of hypotonic saline in symptomatic patients, and in asymptomatic isotonic saline. So furosemide diuresis should be given in these patients. And high extracellular fluid volume, furosemide diuresis in asymptomatic patients, and in symptomatic patients, furosemide diuresis with hypotonic saline. And of course, sodium replacement. Sodium replacement has to be calculated. Sodium deficit has to be calculated. Um, so sodium deficit is normal body water. It is basically the normal body water into 130 minus the current sodium. So 130 is obviously the baseline sodium. So sodium deficit is normal total body water into 130 minus current sodium, right? This is how this hypotonic saline correction is calculated. So in men, the total body water is 60% of the lean body weight, and in women 50% of the lean body weight. The 60 kg patient will be 0.5 into for a woman 0.5 into 60 into 130 into 122, so 300. So based on that, the values have to be substituted, and you will get. Now suppose substituting a body weight of for a 60 kg woman and a plasma sodium concentration of 120, you will get 300 milliequivalents, okay, after you substitute. So total body weight, lady of 60 kg will be 0.5, because total body weight is 50% of lean body weight. So the lady is 60 kg, so 0.5 into 60 will give you total body weight. 130 is anyways the current, the value, and I mean the normal sodium value is taken, the constant is taken as 130, and the current sodium we have considered it as 120. It is low in this patient, right? Now we have got this as 300 milliequivalents. Now 3% NaCl contains 513 milliequivalents of sodium, okay, per liter, milliequivalents of sodium per liter. Now the volume of hypotonic saline needed to correct the 300 milliequivalent deficit will be 300 divided by 513. So 585 ml is needed, rather 513 by 3, whatever. 585 ml is needed. Okay, so this much ml of hypotonic saline is needed to correct the sodium deficit. Keeping in mind the rate of sodium should not rise more than 0.5 milliequivalent per liter per hour for plasma sodium, right? And the sodium concentration deficit, okay, so at least over so it should not rise more than 0.5 milliequivalent per liter per hour, and it should not exceed 130 ml. So this is 120. It should not exceed 130 ml and 0.5 milliequivalent per liter per hour. So approximately 10 hours you can say is needed. Okay, the deficit is 10 milliequivalents. From 120 it has to reach 130, right? 120 it has to reach 130. So 10 milliequivalents deficit has to be corrected. It should be not more than 0.5 milliequivalent per liter per hour. So it will require 20 hours. So this 585 has to be corrected over 20 hours. So it will be 29 ml per hour. Okay, I hope you all got it. Okay, so like I said, this has to be cannot be more than 0.5 milliequivalent liter per hour, and this 120 has to be corrected to 130. So 10 milliequivalents have to be corrected, 0.5 milliequivalent per hour. So you need 20 hours to correct those 10 milliequivalents. This is the amount of hypotonic saline that has to go in that 20-hour period. So per hour 29 ml has to go. So that ended that ended the sodium. Now we'll come to potassium. So hypokalemia is when the serum potassium is less than 3.5. If diabetic, insulin pushes potassium into the cell, ketoacidosis. Hydrogen ion replaces potassium, which is lost in urine in ketoacidosis. So hypokalemia is serum potassium concentration below 3.5 milliequivalents. The cause of hypokalemia can be classified according to whether an intracellular shift of potassium occurred or whether decrease in. So the hypokalemia can be due to an intracellular shift, as with insulin, or it can be classified into a decrease in total body potassium content. Okay. Decrease in total body potassium content, right? So it can be due to the intracellular shift or decrease in total body potassium content. Okay. Now the intracellular shift. Why will the intracellular shift occur? So intracellular shift is basically seen with the. So the first, I will take the intracellular shift into account. Okay. So the causes for the intracellular shift are basically inhaled beta agonists. So beta agonists like albuterol and all, they reduce serum potassium concentration. The effect is mild in therapeutic doses, usually only 0.5 milliequivalent per liter. Okay, but they reduce serum potassium concentration. However, insulin, so when beta agonist is given with insulin and glucose, there is a more marked effect. Diuretics, other factors that promote this transcellular shift are alkalosis, respiratory or metabolic alkalosis, hypothermia. Okay. This can be resolved with rewarming. So these promote intracellular shift. Now the depletion in the total body potassium content is due to renal losses. That is basically your diuretic therapy, magnesium depletion. So magnesium impairs potassium reabsorption from the renal tubule. So it is this plays a very important role. So when there is refractory hypokalemia, one has to look into the magnesium point of view. So if there is hypomagnesemia, there will be decreased absorption of calcium from the renal tubules, leading to hypokalemia. So first magnesium will have to be corrected to get the hypokalemia, to get the potassium back to normal. So renal losses and extra renal losses. So your renal losses are basically your diuretics and your magnesium. Hypomagnesemia. So this is your renal losses, and your extra renal losses will include diarrhea. Okay. So the potassium concentration in stool is normal potassium concentration in stool is 75 milliequivalent per liter, right? But because the stool volume is only normally 200 ml or less each day, little potassium is lost. Normal stool volume is, so per liter it is 75 ml, but usually only less than 200 ml is generally lost per day. But however in diarrhea, the volume of stool can be as high as 10 liter. So in diarrhea, the volume of stool can be as high as 10 liter. So these are the methods of the intracellular shift and the decrease in total. So again, some other causes, we've already discussed these. Decrease intake of potassium not significant, increased potassium loss like diuretics, acid-base imbalances, alkalosis basically, trauma, stress, increased aldosterone redistribution between ICF and ECF. Now clinical manifestations. Hypokalemia results in weakness, flaccid paralysis, respiratory arrest, and constipation. Arrhythmias can be present. It does not produce serious cardiac arrhythmias. However, it can promote conditions that cause it when combined with conditions that cause it is often combined with conditions which lead to severe dysarrhythmias. By itself, it does not cause. So magnesium depletion, MI, digitalis. When these conditions are present along with digitalis toxicity, when these conditions are present along with these things, then it promotes severe dysarrhythmias. Cardiac arrest, postural hypotension. So appearance of U waves is characteristic in the ECG. Treatment. So treatment of hypokalemia is, first is to treat any condition. Right? Treat the condition causing hypokalemia. Okay. Excuse me. So if it is due to potassium depletion, excuse me. Okay, so if the hypokalemia is due to potassium depletion, deficit of 10% of the total there will be a deficit of 10% for every 1 milli equivalent decrease. There will be a deficit of 10% of the total body potassium store. So the correlation between potassium deficit and the severity of hyperkalemia is very different. Okay? So the usual replacement is potassium chloride. So so it is available in ampules from 1, 10, 20, 30, 40 milliequivalents of potassium. They are highly hyperosmotic. Okay, they are very hyperosmotic solutions and must be diluted. Okay, potassium phosphate is also available, which contains potassium and phosphate, and is preferred for potassium replacement in diabetic ketoacidosis because of phosphate depletion is also there. So uh, generally 20 milliequivalent of this Kc potassium chloride is put in 100 ml of sodium chloride isotonic saline and given over 1 hour, right? The maximum rate is usually at the maximum replacement is 20 milliequivalents per hour. So maximum is 20 milliequivalents per hour, but occasionally 40 may be necessary. So when the serum potassium is very low, like less than 1.5 with arrhythmias and all that, even 40 milliequivalents per hour can be given. Okay. um, a central line, a central vein, so a central venous access, it potassium should be given not through a peripheral vein but through a central vein because of the irritating property of, they're highly hyperosmotic, right? So because of the irritant property of the potassium solution, it should be given through a central line. Okay, but if the replacement is greater than 20 milliequivalent per hour, so if you're giving 20 milliequivalent per hour, you can give it through the central line. But if you're giving more than 20 milliequivalent per hour, the infusion should not be given through the central vein because there can be transient, you can cause a sudden hyperkalemia in the right heart chamber, which can predispose to a cardiac standstill. Okay, so that is why the potassium dose should be ideally split and administered via two peripheral vein. So if you're giving 40 milligrams, preferably not to give through the central line because there can be a sudden hyperkalemic arrest because 40 milliequivalents is going directly to the right heart chamber. Central line will go to the direct right heart chamber. So in split doses through two peripheral lines, it can be given. So the serum potassium is usually slow to rise at first. Okay, full replacement usually takes about a few days, uh, especially if the losses are ongoing. If the hypokalemia seems refractory to treatment, this is when you have to check the serum magnesium level because hypomagnesemia can cause refractory hypokalemia, right? So hypomagnesemia can cause refractory hypokalemia, so it should be checked for too if the potassium is not being corrected. Now hyperkalemia, when the serum potassium level is more than 5.5, is more than 5.5 milliequivalents per liter. So you have to check for renal disease. Basically, just a sec. So you have to check for any renal disease. So one has to check for renal disease. So again, hypokalemia is often well tolerated. Hyperkalemia can be serious life-threatening condition, right? So potassium release from, so one is a pseudo hyperkalemia. Now what is a pseudo hyperkalemia? So basically from traumatic hemolysis. Okay, traumatic hemolysis like during venipuncture can produce a spurious elevation in potassium. So it is more common, it is not very well suspected. Usually whenever we see a high potassium level, we just go ahead and correct, right? uh, it has been reported in 20% of blood samples with elevated serum potassium. Potassium release from the muscle distal to the tunicate. So distal to tunicate also can be a source of high potassium levels. So basically, in a asymptomatic healthy patient, if there is a sudden finding in the lab values of hyperkalemia, this should be suspected and a repeat blood sample should be sent. Now, hyperkalemia can be caused by potassium release from cells or by impaired renal potassium excretion. So the renal diseases, basically potassium release from cells or impaired renal excretion, right? A high urine potassium suggests a transcellular shift, and a low potassium indicates an impaired renal excretion. So high urine potassium generally indicates potassium release from cells, and a low urine potassium less than 30 indicates impaired renal excretion. So your transcellular shifts, basically acidosis. So potassium release from cells, that is your transcellular, or impaired renal excretion. Impaired renal excretion, urine potassium will be less than 30. Here your potassium will be more than 30, right? So for your, basically from cells, the reasons are acidosis. For hypokalemia, it was alkalosis. So acidosis, rhabdomyolysis, drugs like the antagonists, digitalis. So basically drugs, rhabdomyolysis and acidosis, right? Now impaired renal excretion. So this impaired renal, I'm going to write it here, impaired renal excretion, basically renal insufficiency, adrenal insufficiency, and drugs. This can lead to impaired renal excretion. So drugs such as ACE inhibitors, beta blockers, ARB, angiotensin receptor blockers, cyclosporin, digitalis, diuretics, heparin can all cause. So massive cellular trauma, that is massive blood transfusions, like given during circulatory shock and all that. Potassium leakage from erythrocytes results when massive transfusion is given. Leakage from erythrocytes results in a steady state rise in plasma potassium uh, levels, and in whole blood the plasma potassium rises at an average of 1 milliequivalent per liter per day. um, okay, so plasma, so with massive transfusion also it is seen. Now decrease, that this is acidosis, exercises, rhabdomyolysis, potassium sparing diuretics, Addison's disease, that is adrenal insufficiency, insulin insufficiency. So clinical manifestations are, early manifestations are hyperactive muscles, paresthesias, muscle weakness, flaccidity can result. ECG pattern changes, that is your tall tented T wave. This is very important. Tall tented T waves. It is the most evident in V2 and V3 precordial leads. Okay. So generally when the serum potassium is 6 milliequivalents per liter, there will be ECG change, and above more than 8 milliequivalents per liter, for sure there will be ECG changes. So as hyperkalemia progresses, the P wave amplitude decreases decreased P wave amplitude, increased PR interval, to increase PR interval, decreased P wave amplitude, and prolonged QRS duration. These changes are very important. You will have to know this. Tall 10 to T waves, V2, V3, decrease in the P wave amplitude, prolonged QRS duration, and increase in the PR interval. And finally, ventricular systole, bradycardia, heart block, cardiac arrest. So the treatment of hyperkalemia is calcium directly antagonizes the action of potassium. So when hyperkalemia is severe, that is above 7 or accompanied by ECG changes, a calcium gluconate is administered and is usually given, right? If there is no response to calcium gluconate, within a few minutes, a second dose can be given. A third dose will not be effective. If there is no response to the second dose of calcium, the response to calcium lasts only 20 to 30 minutes. Further therapies should be initiated. So calcium is actually very effective but lasts only 20 to 30 minutes and only 2 doses. Second dose will not be effective. Okay? So when the ECG changes are more than 7 milliequivalents, ECG changes, and potassium more than 7 milliequivalent. So when there are ECG changes are present, potassium more than 7 milliequivalent, calcium gluconate, %, that is calcium chloride has 3 times more calcium than calcium gluconate. Then if there is any block which is refractory to calcium treatment, so insulin and glucose, so 10 units regular insulin in 500 ml of 20% dextrose. Right? Then 500 ml 25% dextrose over 1 hour. 10 units. So basically everything is 10 10 here. Remember that. It's easy to remember. Right? So this treatment should drop the potassium by 1 milliequivalent for every 1 to 2 hours. Magnesium sulfate is given as a 2-gram bolus IV. Calcium should not be used. So this calcium cannot be used if the hyperkalemia is due to digitalis toxicity, and there is also something known as K-bind. That is K-exalate. K-exalate, that is a dose of 30 gram in 50 ml of 20% sorbitol rectal dose of 50 gram in. It is given as an enema. Okay? That is when there are no ECG changes, everything is stable. This is like a powder. It is given as an enema. Hemodialysis, and in renal failure patients, of course, when none of this is working, so sodium bicarbonate can also shift. This bicarbonate here that you see, bicarbonate can also shift potassium into the cells, but the most common acidotic conditions associated with hyperkalemia is renal failure, and in case of renal failure, insulin dextrose is more effective in lowering serum potassium than bicarbonate. And for the bicarbonate binds calcium and should not be given after calcium is administered. Right, so it is of little value. Now this K-exalate is a resin. It is a polystyrene sulfonate. This is basically sodium styrene is basically sodium polystyrene sulfonate. Okay. It is a cation exchange resin. It is a cation exchange resin that can enhance potassium chlorides across the, it enhances for the potassium chlorides across the gastrointestinal mucosa. So basically it's causing gastrointestinal dialysis. So it can be given orally or by enema and is mixed with sorbitol to prevent any concentration, right? So it causes a gastrointestinal diuresis given via the enema or orally. Preferably we give it orally. So for each milliequivalent of potassium removed, 2 to 3 milliequivalent of sodium is added. So every milliequivalent with this is a sodium polystyrene sulfonate. So every 2 to 3 milliequivalent of potassium removed, 2 to 3 milliequivalent of sodium is added. So if there is no concern about the added sodium, 1 or 2 doses of furosemide can be used to enhance natural uresis. I mean, if there is a concern, if the sodium is on the higher side or something, you can enhance diuresis. The calcium imbalances. Now coming to calcium imbalances, basically calcium, it is mostly in the extracellular fluid and it is regulated. It is regulated by parathyroid hormone. So blood regulated by the parathyroid hormone. Uh, so when regulated by the parathyroid hormone, increased blood calcium by stimulating, it increases parathyroid hormone increases blood calcium by stimulating osteoclast and increases GI absorption and renal retention. Then we have calcitonin from the thyroid gland. So calcitonin from the thyroid gland, it promotes bone formation and increases renal excretion. So hyperkalemia, it is because of hyperparathyroidism, hypothyroid states, renal diseases, excess intake of vitamin D, milk alkali syndrome and certain drugs. So malignant tumors also like hypercalcemia of malignancy. Tumor promotes bone breakdown leading to hypercalcemia. Tumor growth in bone also causes calcium release. It is also seen with hypophosphatemia, this hypercalcemia. So non-specific effects like fatigue, weakness, lethargy, increased formation of kidney stones, pancreatic stones, muscle cramps can result in bradycardia arrest. GI activity, there can be nausea, diarrhea, constipation, abdominal cramps and can be seen as metastatic calcification. Your hypocalcemia, so basically hyperactive neuromuscular reflexes and tetany differentiate it from hypercalcemia. Convulsions can be seen in severe cases. So it is caused by renal failure, lack of vitamin D, suppression of parathyroid function, hypersecretion of calcitonin, malabsorption states, intestinal acidity and acid-base balance, widespread infection of peritoneum, etc. So diagnosis is by Shostak sign and Trousseau's sign. Treatment is IV calcium for acute and oral calcium and vitamin D for chronic. Now coming to, I will deal with over here magnesium. Okay, so magnesium, see the magnesium levels can be normal in the face of total body magnesium depletion. It has to be remembered. Uh, so magnesium hypomagnesemia is basically due to drug therapy. So drug therapy such as furosemide, aminoglycosides, amphotericin, cisplatin, or it can be due to diarrhea. or diabetes mellitus, alcohol use. uh, So when it is due to drug therapy, you will find electrolyte abnormalities. When it is due to furosemide, due to drug furosemide, you will see hypokalemia, aminoglycosides, there will be hypophosphatemia, amphotericin hyponatremia, digitalis, there will be hypocalcemia, cisplatin, there will be cardiac manifestations. With diarrhea, you can see ischemia. Alcohol abuse, arrhythmias will be present. Diabetes, there can be digitalis toxicity. So these are various markers of possible magnesium uh, depletion. The thiazide diuretics generally cause this magnesium depletion. Uh, it is not a complication seen with magnesium depletion, is not seen with potassium sparing diuretics. So alcohol abuse, antibiotic therapy like your aminoglycosides, amphotericin, and pentamidine all cause hypomagnesemia. Then of course secretory diarrhea, diabetes mellitus, okay, because insulin depleted states, right? Diabetes mellitus, because of probably urinary magnesium losses that accompany glycosuria. So the associated electrolyte abnormalities that are seen with hypomagnesemia are hypokalemia, refractory hypokalemia, hence this magnesium will need to be corrected, hypocalcemia. This is because of impaired parathormone release combined with impaired end organ response to parathormone, right? In addition, magnesium deficiency may act on the bone too directly to reduce calcium release, right? Then hypophosphatemia. So it is a cause rather than the effect of uh, phosphatemia. So these are all the other conditions that should be kept in mind whenever decreased magnesium is seen. So you have to keep hypocalcemia, hypokalemia, and hypophosphatemia in mind, right? So it can lead to arrhythmias. So magnesium is required for proper functioning, so it can lead to arrhythmias. So basically magnesium is required for proper functioning of the membrane on the cardiac cells, right? So magnesium depletion will depolarize cardiac cells and promote tachyarrhythmias. Digitalis and magnesium deficiency act to inhibit membrane pump. Magnesium deficiency will magnify digitalis effect and promote severe digitalis cardiotoxicity. Neurological findings will be uh, basically there will be ataxia, so there can be CNS findings such as ataxia, slurred speech, metabolic acidosis, excessive salivation, muscle spasm, generalized seizures, progressive obtundation, right? And it is usually treated, the treatment is by magnesium replacement. It can be given oral or it can be given parenterally also. Orally, they are available as enteric coated tablets, and parenteral is magnesium sulfate. Yeah, each gram of magnesium sulfate has 8 milliequivalents of elemental magnesium. So this has to be remembered that each gram of magnesium sulfate has 8 milliequivalents of magnesium. So this was about hypomagnesemia. It can be life threatening, and magnesium accumulation. Hypermagnesemia is generally seen with renal insufficiency, and hypermagnesemia is associated with the hypo, when magnesium level as it increases, like at 4 milliequivalents there will be less reflexes, hyporeflexia. At 5 milliequivalents there will be first degree AV block. More than 10 milliequivalents of magnesium if present, there will be complete heart block, and more than 13 milliequivalents, so that is with hypermagnesemia. So hypermagnesemia. So hyporeflexia, when it is more than 4 milliequivalents per liter of magnesium. Then first degree AV block, more than 5 milliequivalents per liter. Complete heart block, more than 10 milliequivalents per liter. And cardiac arrest, more than 30 milliequivalents per liter. Okay, the treatment is hemodialysis. It is the treatment of choice. Okay, hemodialysis is a treatment for severe hypermagnesemia. Intravenous calcium gluconate can be used temporarily until dialysis is started. So that's it guys for today on the electrolyte imbalances. I shall see you all again tomorrow. Do use my code SASHK and avail your 10% discount. Thank you guys. See you all tomorrow.